My name is Paul Mueller. I am a physician at Mayo Clinic in Rochester, Minnesota. I'm an associate professor of medicine. I am the chair of the Division of General Internal Medicine and the co-director of the program in professionalism and ethics at Mayo Clinic. Our article's title is Ethical Analysis of Withdrawal of Ventricular Assist Device Support, and this article will appear in the September 2010 issue of Mayo Clinic Proceedings. Well, we have several lines of research that are following this study. One is actually looking at how many of these patients actually engage in advanced care planning. What we found is that actually less than half have formal advance directives available to their clinicians. That's the report of that study is forthcoming. We've also implemented a proactive advanced care planning process for patients at Mayo Clinic who are receiving left ventricular assist devices. So at the time of consideration for implantation of this device, or in patients who already have them, they meet with a social worker and a palliative medicine specialist to discern what their life or their health care related values, goals, and preferences are. And then they articulate those in an advance directive so that when the time comes and the patient is unable to make decisions for themselves, that we have an idea of what their goals or values would be in terms of managing the device at the end of life, such as turning it off if there's no hope for recovery. In the study, we reported the features of 14 patients with end-stage heart failure supported with left ventricular assist devices who requested, or their surrogates requested, withdrawal of that support, the turning off of the device. These devices are relatively new to clinical practice, and the number of patients who've received them at Mayo Clinic has grown over the years. During this period, a number of these patients have requested, or their surrogates have requested, withdrawal of ventricular assist device support. These requests have raised ethical concerns, specifically whether or not turning off these devices is akin to euthanasia or physician-assisted suicide. After all, death inevitably follows withdrawal of ventricular assist device support. In the study, 12 of the 14 patients did not have decision-making capacity, so we had to the physicians involved in their care had to rely on surrogate decision-makers or the patient's previously expressed wishes in the forms of advance directives to make the decisions. Because heart failure is a growing problem in the United States, more patients are being offered left ventricular assist devices to support them. Some of these devices are used to bridge them to heart transplant, also known as bridge to transplant, but others are receiving this novel treatment as destination therapy. That is, they will have the device for the rest of their lives. While this is a promising new technology and many patients benefit from them, from the technology, some patients experience complications such as infection, stroke, multi-organ failure, and therefore clinicians who care for these patients inevitably will encounter some of them who request, or their surrogates request, withdrawal of the device. We then described the clinical characteristics of these patients and the reasons for the requests. We then conducted an ethical analysis of the requests and whether or not carrying out such requests is ethically permissible and legally permissible. What the results of this study mean for patients is that they shouldn't feel that once they commence with a treatment that they have to stick with it forever. Because somebody is committed to a life-sustaining treatment such as hemodialysis, mechanical ventilation, a feeding tube, and now a ventricular assist device, does not mean that a patient has to stick with that treatment the rest of their lives. Patients, when they perceive that the burdens of the treatment outweigh the benefits, and after a thoughtful discussion with their loved ones and their clinicians, determine that the treatment is no longer beneficial to them, it is ethically and legally permissible for them to request the withdrawal of the treatment. And death that follows such withdrawal should not be perceived as suicide, but rather allowing a natural death due to the underlying disease that necessitated the life-sustaining treatment in the first place. After all, patients have the right to refuse any and all treatments, and forcing a treatment on a patient is not only unethical but illegal. And likewise, courts have consistently ruled and ethicists have consistently determined that withdrawing such a treatment is similar, or if not the same, as refusing it in the first place. The other thing that we've learned that patients should and families should derive from this study is that when faced with a life-threatening illness that necessitates a life-sustaining treatment, patients and their families and their clinicians should engage in advanced care planning, including the completion of an advance directive. We found in our study that not all of our patients did this, and at times that leads to some concerns, because we don't really know, especially in a patient who doesn't have decision-making capacity, what that patient might have wanted in that situation. An advance directive, something in writing that guides us on how to manage the device at the end of life, can be very helpful, not only for clinicians, but also for family members who might feel burdened about making a decision to withdraw a life-sustaining treatment. In my own experience, I've had a lot of patients who've expressed a lot of relief because the patient put it in writing. If I'm dying of a disease and there's no hope for recovery, turn off the left ventricular assist device or withdraw the dialysis. You see the concern lifted from that, or the burden lifted from that loved one, because the patient had already made the decision. An important takeaway message of this article is that there is no treatment that has unique moral status. Simply because we started a treatment does not mean that we can ethically and legally stop it. There is no life-sustaining treatment such as dialysis, mechanical ventilation, artificial hydration and nutrition, implantable cardiac devices, including assisted or left ventricular assist devices, that must be continued simply because we started them.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.